Welcome to our live webinar. I'm Dr. Sheila Brooks. I'm President, Founder, and CEO of SRB Communications, and I am very pleased to be your moderator today. And a very special welcome to all of our grant recipients. Today, we're going to discuss the CDC's national initiative to address COVID-19 health disparities among populations at risk and underserved, including racial and ethnic minority populations, and of course, rural communities. Now, we ask that all of you that are here on the live webinar, please mute yourselves and turn off your cameras if you haven't already. And we're going to begin this webinar with opening remarks, followed by our panelist presentations. And then we'll have enough time for all of you to place your questions in the chat, which is the Q&A that will be followed by the panelist presentation. So now for our opening remarks. Let's welcome Cassandra Martin Frazier, the lead for the Grants and Cooperative Agreement Team, commonly known as GCAT. Ms. Frazier?
Yes, hello everyone and welcome. We are so overjoyed to have you today. As stated, I am Cassandra Frazier, Team Lead for GCAT within the proposed Office of Health Equity at CDC. The GCAT offers technical assistance and training to the recipients of the 2103 COVID-19 Health Disparities Grant. And we are excited to offer today's training to you all, and you are in for a real treat. Today's training will cover crisis communication and data and surveillance, areas in which many of you are focusing on through the grant. Our hope is that you will gain takeaways that can inform your work. Now I'm excited to turn it over to the Office of Health Equity's lead for the Minority Health and Health Equity Science team, Dr. Rashid Njai, for remarks.
Hello and good afternoon. As mentioned, my name is Lieutenant Commander Rashid Njai, Team Lead for Minority Health and Health Equity Science. And I just wanted to offer a few words. I think the current climate we find ourselves in as a country requires a new commitment to just and innovative ways that promote health. And through stronger relationships with and the engagement of community serving organizations and leaders, academic partners like Howard and UCLA, as well as national, state, and local public health. That is important for the work we do. We look to amplify investments in community partnerships and sustainable action grounded in data-driven and evidence-based approaches to address the current and historical crises we're facing. This work requires new directions in structural drivers, social determinants, and health equity. Towards this effort, the CDC's Office of Health Equity and the Minority Health and Health Equity Science team is excited to share the collaborative work of Project REFOCUS today and related work in the future that amplifies community engagement, innovation in applied health equity science approaches and frameworks, and expansion of the public health workforce to include citizen scientists, journalists, as well as allied health workers and professionals such as community health workers and social workers. It is my honor to really offer these opening remarks. And I just want to leave you with, if there are any questions related to this work or the work of our team, please feel free to reach out to me directly using the contact information provided. And I'd now like to turn the conversation over to our moderator, Dr. Brooks.
Thank you so much, Ms. Frazier and Dr. Njai. We appreciate you joining us today to discuss this important topic, crisis communications during COVID-19, lessons learned from Project REFOCUS, Communities of Practice. And I also want to again thank all of the attendees, all of you who are joining us today. We very much appreciate you joining us today, and we have a very exciting presentation and a discussion for you up ahead. So please continue to keep your mics muted, your video off. We thank you for your participation today. You will have a chance to ask questions, which you can leave in that chat at any time during the panelist presentation. We'll be prepared to answer these questions immediately following the presentations. But now, for the next 30 minutes, you will hear from two public health experts. Let me begin by introducing both of them now, so that we'll then hear from each of them for approximately 15 minutes each. We're going to begin first with Dr. Monica Ponder. Dr. Monica Ponder is an assistant professor of health, communication, and culture in the Department of Communication, Culture, and Media Studies in the Kathy Hughes School of Communication at Howard University. She is co-principal investigator of Project REFOCUS, Racial Ethnic Framing of Community-Informed and Unifying Surveillance, which is Project REFOCUS. Project REFOCUS conceptualized and developed a novel set of tools communities can use to monitor and address how stigma and racism affect COVID disparities, with the goal of creating a more effective response to COVID-19 and certainly other public health crises. Also joining us today is Dr. Chandra Ford. Dr. Ford is founding director of the Center for the Study of Racism, Social Justice, and Health at University of California, Los Angeles, as we all know, UCLA. She recently joined Emory University's faculty, holding dual appointments in the Rollins School of Public Health and the Department of African American Studies. She is the other co-principal investigator of Project REFOCUS. Let our discussion begin.
Thank you. We'll start with Dr. Ford.
Allow me to share my screen. Thank you for that warm introduction, and it is really a pleasure to be here. I appreciate the opportunity to speak with you all. I am sharing what I've called selected notes from adequacy of existing surveillance systems to monitor racism, social stigma, and COVID inequities, a detailed assessment and recommendations from Project REFOCUS. This was a presentation that we delivered at the 2022 APHA. So for those of you who paid for access to those recordings, you can find the fuller presentation there. There are no conflicts of interest to disclose. I do want to acknowledge that this work was supported by funding from the Centers for Disease Control and Prevention, the CDC Foundation, the National Institute of Minority Health and Health Disparities, as well as a COVID Research Award from the UCLA David Geffen School of Medicine. I must acknowledge the many individuals who have played a role in helping us to develop a surveillance system and dashboard, and who are continuing to be involved with us. And lastly, I do want to acknowledge that this work is based on lands originally inhabited by and cared for by the Gabrielino Tonga peoples of Southern California, who are still with us, but no doubt displaced from the institutional lands. And so we make that acknowledgement, especially in a project rooted in equity. In the time allotted me today, I want to provide a little background on how we're approaching the development of a dashboard, and with a consideration to the potential harms that public health surveillance may inadvertently do. We conducted a pilot to try to score ways in which that harm might be mitigated. And so we'll share just a very high-level introduction to that piloting process and the rationale behind it. And I'll close with some challenges and recommendations. As background, the field of public health relies heavily on a myriad of surveillance approaches. These are important, as you all know, to detect threats to population health early, but also to monitor the health and healthcare of the population. The information obtained through surveillance directly informs the development of interventions to prevent or mitigate public health disasters. Now, the COVID pandemic has shown that public health crises do not occur in a vacuum, They intersect social stigma and racism, which jointly impact the very communities who are of most interest for public health and health equity intervention strategies. The COVID pandemic has also then raised concerns about the adequacy of traditional public health surveillance systems to collect relevant data that include attention to stigma and racism in real time. So we're interested in information to help us address concerns of population health, as well as health disparities and health inequities, and in particular, the root causes of those disparities, including racism. Incoming director of the CDC, Rochelle Walensky, declared racism a serious threat to the health of the public within a quarter of beginning her term in 2021. So this has really shifted and anchored public health strategies in recognizing that racism is not just a social or sociological issue, but it's one that we should use our public health tools and strategies to address. Much research has supported this statement, but the question is, what are the implications for public health practice? So our goals have been on this project, in terms of the data science team, our goals have been to develop a conceptual model for a novel surveillance system, one that can capture both ways that social stigma and racism are co-occurring with the public health pandemic. In this case, we're focused on COVID, but certainly there will be other future pandemics or public health crises. A second goal is to develop a dashboard through which people can actually access those surveillance data, and then to begin to pilot these tools among 6 diverse communities. And I do want to highlight the communities here because these are communities that are already doing phenomenal work, and I believe it would be an important opportunity to build on with you all, with your awardees. I would really like to flag some of these. So in Albany, Georgia, the Phoebe Putney Care System. In the Bronx, New York, the community-based urban health plan. Heal Detroit in Detroit, which is based at Wayne State University. In West Helena, Arkansas, the Heart Healthy Communities Project, which is based at the University of Arkansas for Medical Sciences. The San Antonio Group, which is a collaborative involving the University of Texas at San Antonio, as well as the San Antonio City's Innovation Division, and Wake County, North Carolina, which is anchored at Shaw University and working very closely with Wake County Health Human Services. Much of what I'll be sharing with you today can be found in several publications. The first is, although we're thinking about novel ways to address the co-occurrence of stigma, racism, and COVID, we don't want to totally discard all that we have learned over the generations of public health work. So our first step was to conduct a series of rapid scans to identify different existing surveillance systems early in the COVID pandemic and see what we might learn from them that could inform a future novel COVID surveillance system, sort of equity and racism-oriented COVID surveillance system. In evaluating these systems, we use the standard criteria that one might use to evaluate public health systems, such as the usefulness of the system for the information needs of health departments. But in addition to those, we also added several other criteria by which we evaluated each system. These included, for instance, information on race and ethnicity. Is it included in the system? And if so, how is it collected? Which categories are included? What measures of stigma, if any, are included in the system? Are those measures validated, for instance? And then are there any indicators of racism that the system includes? And if so, what relevant measures of racism are included? And finally, what potential harms might there be due simply to surveillance that are linked to that system? So to what extent might the system contribute to harm of, in particular, racial and ethnic minority or vulnerable populations, just based merely upon the fact that it involves surveillance. So this work is rooted in work that the COVID-19 Task Force on Racism and Equity has been doing since the beginning of the COVID pandemic. And early in the pandemic, we recognized that there were some things that we, as largely academic researchers, needed to do to ensure the work we are doing adheres to principles of equity in real life. And we published a blog in which we charged ourselves and our colleagues to do 4 things. First, to self-monitor. How do we do research and practice in the community? Does it reflect what we espouse in terms of equity and power balances? 2, to track the nation's alignment with global principles around equity. 3, to organize in order to hold governing bodies accountable. So, for instance, community health advocates are often already organizing to do this. And as academic partners, we see our role as bringing the tools and resources that our academic privilege and research expertise affords us to that ongoing work for shared partnership toward equity. And then finally, to act, and to do so in alignment with strengthening community power in this coalition of support across community and academic and other stakeholders. This work is rooted in, grew out of the work of the Public Health Surveillance Group, which is a community campus collaboration between the UCLA and CDU. CDU stands for Charles R. Drew University, the historically Black college and university in Los Angeles. This UCLA CDU COVID-19 Task Force on Racism and Equity. And the goals have been to explore, describe, and organize against the harms that can come from surveillance. And specific focuses are how data gathering, and data sharing can criminalize or recriminalize individuals and families and communities, and also how it may harm Black, Indigenous, and people of color or BIPOC communities. An important way that the surveillance work group, the Public Health Surveillance Work Group, has carried out its work and continues to carry out its work is by offering public-facing workshops and webinars. And here you see a flyer from one of the webinars held some time ago, hosted by Stop LAPD Spying, which is one of the lead coalition members here. The focus here was on the police state orientation, race, and public health in the time of COVID. So our goal is to not to discard public health surveillance altogether, but to involve it, to use it to draw on its strengths, while at the same time being aware and attentive to its potential harms, because we're concerned with ensuring the well-being, optimizing the health of racially and ethnically minoritized populations and of other marginalized populations. I do want to share that in the limited time I have here, I'll give you a high-level overview, but you'll be able to find much the sort of spelled out version of this information in this paper referenced here, which is in press now at the Open Access Journal Ethnicity and Disease. If you just Google ethnicity and disease, you'll be able to find a number of papers focused on that the task force has been working. So our strategy has been not to discard public health surveillance, but to think about scoring the surveillance systems that we use, giving them scores of how likely they are to support information sharing with law enforcement in ways that might lead to the following things. So I'll mention them shortly. So the goal, develop this novel equity-based system to score the surveillance systems, and to assess the surveillance related harms based on the type of information that they're gathering and whether there's evidence that there's information sharing, that the public health surveillance systems are sharing information with law enforcement and vice versa, although we're primarily concerned with the information being shared from the public health community to the law enforcement community. And the scores are based on whether there's potential or actual risk of harm, and whether and we're specifically focused on harm for BIPOC populations and marginalized or vulnerable populations, in particular populations such as homeless people or formerly incarcerated people. We use the term harm to refer to these very specific types of risk for increased exposure to policing, to detention or incarceration, to deportation, or to disruption of one's access to social services. All of this work is guided by public health, critical race praxis. It's a rather academic sounding term, but it really just means that we're constantly charging our own selves with living up to, in how we operationalize this work, living up to our own principles of equity. To develop the scoring system, we drew on input from an expert panel. Well, we reviewed a number of historical case studies and also contemporary case studies in which public health data were used by law enforcement and resulted in these potential harms. The piloting was based on systems identified previously by our team during the course of the COVID pandemic through these rapid environmental scans. And we organized the systems into three main categories: those that primarily focus on sharing information about, presenting information about COVID-19, those that are not specifically focused on COVID-19, and those that are focused on documenting stigma or racism in populations. And it's to these systems that we applied the scoring system. We identified a number of strengths and several limitations. Let me just highlight very quickly here. That one of the strengths of the scoring system is that it relies on publicly available data, which means that health departments, for instance, do not have to have a subscription to any particular service in order to apply a scoring system. The scores are easily calculable, and you'll find those in the paper. I didn't want to elaborate it on here because there's not time to elaborate on it fully, but essentially there are 4 categories that a score results in, and one can calculate it pretty straightforwardly. Another strength is that this approach, the scoring system, helps to provide health departments and others with some rationale for shifting the focus of surveillance efforts from extracting more and more information from individuals and communities who are already heavily surveilled, to beginning to shift our surveillance tools toward the institutions that play a role in remarginalizing communities at times. Meaning, these institutions play a role in their services that communities access or individuals access, and not necessarily intentionally marginalizing or remarginalizing communities, but in some cases, they do play a role, however inadvertent or unintentional that may be. Limitations include that obviously in this piloting, we may not have included all systems. This was not an exhaustive assessment of systems. Some of them may have been excluded because they were not available publicly, and others may have been excluded because they were not yet produced at the time that we conducted the assessment of surveillance systems. So how do we move beyond just a health disparities orientation, and even from moving beyond simply documenting racism toward both documenting racism and striving to undo it, not only in society out there, but also amongst ourselves and how we carry out, how we operationalize the collection of data, the production of dashboards. We have to deal with the continuously evolving information needs that exist. And this can be a challenge. And this is something that we have experienced over the course of working on our dashboard. It's important to deal with this question about the ubiquity of data on minoritized populations. So most of the data that's available on individuals and on communities is available about people who are already subjected to heavy policing and surveillance. And so it's very tempting to rely on those data to do the work. And what we would say it's important to push back against that tendency. And then finally, there's a pervasive lack of explicit attention to racism. And so the statement by Director Walensky that racism is a threat to the health of the public requires us to provide evidence of that. So our surveillance tools must mature in order to be able to be responsive to that charge. Ultimately, part of what we must think about is not just the numbers, but the stories. What is the story and who gets to tell it? These are questions of power. Those who create the data, the surveillance systems and the dashboards are the ones who hold the power in being able to tell the narrative. So if we're doing this work, we have to be aware of that. We have to be attentive to that and think about how can we share power so that the stories are told are really originating, truly originating with those who are most impacted by public health crises, but also by our surveillance tools. In closing, just a few items I want to share with you all while I have this platform, just based on the challenges and strengths of what we have learned over this period of time working on Project REFOCUS and trying to develop a dashboard that can be responsive to measuring the co-occurrence of a public health crisis and a social crisis, that of racism and social stigma. Our biggest challenge, believe it or not, has probably been pandemic-related work challenges like staffing and organizational changes. How do you support community-based organizations that are great partners, but have limited resources to be sustained over the course of the pandemic? Another lesson we learned is that continuous access to data on the institutional and structural drivers of inequities is hard to find. Again, it's easy to get information about individuals who commit crimes. It's harder to get information about the institutional structural drivers in communities that might lead individuals to be more likely to commit crimes. We also learned that it's, balancing this sort of easy access has to be done against the potential longer term harms, not just immediate harms. And this is important because, again, the pandemic is evolving, the information needs are evolving, the technology is evolving. We do not yet know how this technology will be used in the future. So we have to try to anticipate ways in which it might harm not only now, but in the future. And then finally, I'll say the question of data granularity. We have learned from our community partners that what would be most useful in reducing and mitigating the pandemic is having data that are local and very granular, even down to the neighborhood level. But that presents a number of challenges, ethical challenges, even in some cases, we've all discussed about because with respect to this potential harms, because it might reveal, for instance, coming from LA, communities where there are high numbers of people who are undocumented, and that may place them at risk for deportation, detention, etc. So we recommend that we all acknowledge the potential for public health strategies and tools to impact communities adversely, right? So our tools, we know our tools can have a positive impact. It's also important to acknowledge they may adversely impact communities. We recommend increasing transparency regarding data and data sharing practices. And this is because this way we can share that responsibility with communities about knowing what the constraints are that we're within which we're working. And finally, we recommend limiting the inclusion of data in surveillance systems if the data can be shared with law enforcement, if the data are likely to be shared with law enforcement or social services in ways that may harm communities. I thank you for your attention. And with that, I will turn it back to Dr. Brooks.
So I'll do part two and pick up where Dr. Ford left off before we turn it over to Dr. Brooks for questions and discussion. So we're just going to roll through. May I have my slides, please? So I want to just, again, thank you guys for joining us today as we share the work of Project REFOCUS and what we've been up to in the last year or two and how this work has implications for state, local, public health, as well as community partners. And so today I will be speaking more on the communications and community engagement side of this work on behalf of the Howard University team and my co-presenter, Dr. Goodman. Next slide. And so Dr. Ford mentioned the Project REFOCUS framework. I'm going to revisit that and actually explain where the communications connections come in at, and then share what we've learned in terms of crisis communication, public health communications, and some of the implications for phase 2. Next slide. And so this is the conceptual model for Project REFOCUS. As Dr. Ford explained in very helpful detail, there's so many data inputs that are valuable to public health decision-making, emergency response planning, intervention design. And the point of Project REFOCUS is to bring in this real-time public health monitoring so that we can have a community-informed response that is reflective of immediate needs. And so this includes bringing in several data inputs that she mentioned, but we hope to get to a point of a signaling, which is you see at the bottom here, so that all of these factors together on a local level can inform a local community crisis response. Next slide. And in terms of the communications implications, these last two pieces are the ones that are a bit more fluid in that it really takes interpersonal communication, understanding how media frames can impact public health behavior, media frames can impact social stigma, and even just how people make decisions, particularly from a place of safety and a place of their own personal risk assessment. Next slide. And so as Dr. Ford mentioned, there's been much conversation in the public health community about racism being its own epidemic and historical harms. But my question I want to pose to you is what happens when the crisis never ends? How do we do public health crisis communication differently? What does that mean? And so Project REFOCUS is looking to explore options and opportunities there. Next slide. And we've learned a lot when it comes to communications and community engagement. Of course, the data science piece is critical to the framework. And when you layer all of that, it really is an optimistic framework that we hope to expand into other communities. But as a health communicator, really the most important finding of this work so far is really understanding our approach to social listening. So that in public health, we're less paternalistic, we're less reactive, but we're actually integrating real-time inputs from the communities. It is my professional opinion that communities, people are speaking to us as public health practitioners and institutions all the time. The question is, are we listening? This means that anything we do needs to, not just rhetorically, but in practice, center a community-informed approach. And one of the main things that we know in terms of how we can best drive and influence and support personal decision-making, this collective decision-making, is to understand and keep centered the critical role of media and interpersonal communication, particularly during crises, during times of high distress. And remember, sometimes the crisis doesn't end. And so you have populations that are in a constant state of need in terms of feeling connected and rooted. And so what does it mean to transfer a creative, exploratory endeavor like Project REFOCUS into transformative practice for state and local public health? That is exactly what Project REFOCUS is exploring right now. And to do this work well, we must collaborate across multiple institutions and partners. So we have a very long acknowledgement list at the end, and you'll see that it really takes so many people to really figure out not just this idea of Project REFOCUS, but also what it means to actually put it into practice. Next slide. And here's one of my favorite quotes. And it really speaks to just our own lived experiences and how that in itself are data. And so I love this quote about just imagining what new inputs and context we can get and bring to the table in public health intervention design and decision-making if the people who actually lived in the distress and issues and things that we study, if they were at the table and able to advise on how best to move forward. Next slide. And so this is why we have a community-informed approach. And there's several guiding questions that really framed our work in phase one and continue to frame our work in phase two. And it's really about how can we make sure lived experiences are added to and complement, and I would even say weighted in the same manner as our traditional surveillance systems and data inputs. Also, news media frames. What do we know about how news media frames impact health behavior? How can we explore that deeper and more richly? Next is ethnic niche media. I would even say citizen journalists, community media, multicultural media. These go by several names, but the fact that there's a high degree of trust necessary to make sense of information and to make the best decisions. One term I use in my work is the kitchen table, living room, safe spaces of conversation where people may hear information about what to do, what's going on in terms of our public health ecosystem, but then also, what does it mean for me? What does it mean for the people I care about? And this is how people make those connections, which is why public health must remain local. It must begin with grassroots approaches and inform the ecosystem outward. And so again, I mentioned the sense-making strategies, and that this is really also a key part of health communication. Next slide. And so Dr. Ford mentioned our community partners, but I cannot shout them out enough. These are the shining jewels and the bright spots of this work. And so it's one thing to stay in theory and to actually have a design and an idea and frameworks and conceptual models. It is another beast to actually work with people who are living the issues that we observe. And so our community partners have been instrumental in us really making sense of even this project and what makes sense in practice and what is truly needed. And so I want to make sure I give a special acknowledgement to our community partners. What you see here on the screen is also, if you go to our website, projectrefocus.com, there's several graphic campaign materials that we made in phase one that really express a lot of the sentiment with the communities that we've engaged so far. Next slide. And so what does it mean when we talk about all these inputs? What does it mean to have a signal and to inform a crisis response? Let's explore that more deeply. Next slide. So we actually looked at this. And so what we found in phase one is that traditional media, they do the work that we expect them to do. They report on health risk. They report on prevention and education and information about health resources, and even explore medical scientific issues. But what happens in multicultural press, and I'm going to use that as a universal frame, but when I say multicultural, I'm mentioning the citizen journalists, the community media, the niche media, the cultural media. When they reported on the same stories, what our work has found is that the context matters. And so it's not just the data. It's not just what is occurring in the community, but also what are the economic consequences, the political and legal issues in terms of policies and impact on people's even status and safety, societal problems in terms of cultural and religious frames or contexts that are important in terms of how people really truly make decisions in a health behavior context. Next slide. And this even continued around when the vaccine was approved in terms of the multicultural press continuing to not just talk about the vaccine and what it means. And there's a lot of debate, of course, on that in the traditional media in terms of questions that the public had, but also framing COVID-19 as a societal problem. We noticed a shift in media frames across multicultural press. And then even during this time, and even we see it even now continuing to be explored, how COVID-19 intensifies mental health challenges and what it means in terms of really having continual distress and trauma and grief that people are working through. This is something that was emphasized by the multicultural press. And the multicultural press, ethnic media, citizen journalists in their stories, there was a theme, a consistent pattern of them also emphasizing collective care. Community and community centers, resources centered to how groups can make sure they remain connected. And so that is an important piece. Next slide. And so in phase two, which began last year, we wanted to extend this work and really understand how public health as an institution can strengthen its work and really support the work of multicultural media. And so here's some questions that we have asked. We've actually spoken with many journalists, starting off with our community partners in those 6 sites. And I put the byline here in terms of where we've actually started our interviews with journalists, but really help us understand the landscape that you're working in and how your experience working with public health institutions. And I have a couple of slides here that will talk about even just more of a in-depth of what we've heard so far, but what are your needs and how can public health best work with you? And then also we want to make sure we fold them into the dashboard, giving them direct access to these data points and inputs that are in part of Project REFOCUS. What does that look like? And then also, what resources do you need to really continue telling stories within your community? Next slide. And we actually have more presentation, like I said, that really goes in depth, but I want to make sure that I pause here and just give credit to even just 2 of the journalists who made time out of their busy schedules to speak with us. And I think one of the most resounding themes is that many of these multicultural journalists and citizen journalists, they're living the experience that they're telling and writing about. And that brings its own visibility. And also there's a huge passion to make sure that they support the sense-making needs of their community. So it's not so much reporting as much as really sitting down and exploring in depth, even in ways that may not be supported editorially. This is one thing that is has been consistent across themes. Next slide. And so here's another comment from the Bronx from one of our partners, a journalist in one of our partner communities. And if you just connect the dots with what we saw in the news media in terms of the migration that happened from some cities when COVID started, and this is an experience from a journalist, a racialized journalist of color, speaking about just what implications that meant for people who were left in that community, and then even just having to navigate the newness of COVID and the state unrest. Their experiences and their stories are just those that I really encourage everyone to really explore and give thought to in terms of the critical role these actors play in the public health ecosystem and helping people make sense of their reality and their needs. Next slide. And so if you go to our website, we do have a link to the conversation. We brought together several journalists. So this is in addition to the interviews, but the conversation was very rich. This conversation happened in February, and it is on our YouTube channel. And the stories and anecdotes and recommendations that journalists have made are just, I would say, probably one of the most significant findings from a communication side, crisis comm side with this work. And I encourage you to go check out the conversation, let us know your thoughts and your feedback, and even just your experiences with working with media in your own communities, and really what you found to work and what is needed. We're intently focused on this and actually identifying ways that, again, these relationships can be strengthened. Next slide. And we're going to continue the conversation. And so on March 16th, we will be hosting a citizen journalism one-on-one workshop for the public. And so what does it mean to play a part in community media during public health crises? And so here's a QR code if you want to actually do a screen grab during the webinar, but also the information is on our website. But there's also best practices in terms of if you want to tell your, we're all citizen journalists, even if we do not, we're not affiliated with a publication. We all help people we love in our community to make sense of their world. And so I invite you out, we invite you out to actually participate and register in the next event. Next slide. And before we go to Q&A, I want to make sure that we are very intentional about inviting you to be collaborators of Project REFOCUS. We are here to learn and work in tandem with community members. And so whether you are more interested in the dashboard technologies and seeing how these community partners are tailoring the dashboard to reflect their local level crisis needs, we're happy to connect with you and talk with you more. If there are education or training needs in terms of crisis communication and what that would look like in terms of what it means to really do crisis communication in more of a culturally responsive, timely manner. We'd love to talk more about our lessons learned and just really even explore what it looks like in your community. The more communities we have in conversation helps us to learn and really tweak the framework in terms of the possibilities of what this can look like for transformative public health when crises may never end. Next slide. And before I turn it back over to Dr. Brooks, so there are two acknowledgement slides. There are a host of people behind the scenes that this project just would not be possible without. And so I want to first give a special acknowledgement to just all the people at Howard University. I love Howard University. And I've loved the experience to be able to work with colleagues on this project, and equally so the UCLA colleagues. Next slide. We have wonderful CDC technical monitors here. You met Dr. Njai at the start of the call, as well as Judy Lipschitz, as well as other CDC collaborators and advisors, the CDC Foundation, our evaluation team, which is out of the University of Washington. We have several project partners and community advisory boards, technical advisory boards, and again, a special thank you to all of our community partners. That concludes my presentation, and I want to turn it back over to you, Dr. Brooks, for question and answer from the group.
Absolutely. Thank you so much, Dr. Ponder. Thank you as well, Dr. Ford. What a great resource of information we've been given through the chat. So many thank yous to both of you on what we have shared today. Attendees, I do want to mention now, you will receive an email with a recording of today's session. You can also learn more about Project Refocus by going to the website, projectrefocus.com. I'm going to begin with a comment, Dr. Ford and Dr. Ponder, because I mentioned earlier that everybody was thanking you. Here's one significant comment. Thank you for the work you all are doing. I appreciate the gift of this presentation. And then I have a couple of questions. So first question to our presenters, what would a collaboration with Project Refocus, what would that look like? Coming from any of the community partners or others that might be interested in this work?
Dr. Ford, do you want to take that from a technical side and I can pick it up from a communication side?
Mm-hmm. I would start by saying there is no limit to what a collaboration might look like. That part of what we are trying to do, and the term refocus gets at it, is to open up ourselves to ways of solving the problems that communities are facing that are not limited to just pulling out of the toolbox we're used to carrying. So part of it is that you all have innovative ideas, and we would want to work with you to operationalize those innovative ideas, or to work further with them, or to think together, work together to try to address the ways that they may, for instance, work on harms. Another thing I would have to mention is a collaboration might look like working with some of our pilot sites that we've mentioned, or amongst the pilot sites in particular, to think about longer term sustainability opportunities. Like, what would it look like to have community-led projects or support systems built out through communities. So that's just one of, I would say, an infinite number of possibilities that might be pursued.
Thank you, Dr. Ford. And I would just say on the communication side, there are probably two key areas. What does it mean when there's a public health decision-making opportunity, what does it mean to really use this framework? And so you have the data inputs that are the dashboard, but how do we fold in our media family, our community partners, as well as the voices, the interpersonal communication, the things that we hear that are rumblings before it becomes a disease outcome. And so advisement on that side in terms of really what other communities are doing. So following best practices, that's definitely something we can do. And then even just what it means to practice crisis communication using this model. I think there are education opportunities. We've also explored, and I think Cassandra and Dr. Njai can follow up with you on this, but we are hosting a summit for our community partners to really share their work. And so we have talked about inviting, just having a few seats for 2103 awardees to be a part of that conversation and observe what these communities have learned. And so you won't hear from us, you'll hear from the communities themselves and look at what data inputs they found valuable and what it looked like to actually implement this work in real time for them. And I think that probably is the most valuable learning opportunity we could give in the immediate. And so that's information that we can share forward through your project officer.
Okay, Thank you so much for that. And I do have another question here. This question says that our team has sometimes struggled to reach historically marginalized groups within our community. So what other support or resources can Project Refocus provide for communities and organizations that's not in this pilot program, that won't be at the upcoming event?
Yeah, so we didn't, I don't think Dr. Ford, we may have touched on it, but a huge part of our pilot site partnership requirement is for them to set up a community advisory board. And so while the institution itself may not have these relationships, there are people who are trusted that have those relationships. And so all of our communities have had to figure out that question of who can help, as I'm from the South, so who can help carry the water in terms of the messages and the needs and to bring things back. And sometimes these players are informal, they're quiet. And so even just how we talk about advisory boards, some people don't like that name. They want to, it's more about having a central role. There's so much to learn and explore there. So I would say if that's a question, we're happy to set up a conversation. Number one, really sharing what communities have learned, or maybe even making sure that you can hear from communities about what they've found to be helpful in terms of making those connections, but also understanding that influence sometimes happens quietly. And this is all a part of relationship building, which is a part of crisis communication and public relations. And so that's in the education box in terms of really how we can help solve some of these problems that really don't have a standard blueprint, but need to be tailored per community.
Dr. Ford, did you have anything else to contribute to that?
I have nothing to add on that at this time. I think that's good.
Okay, thank you so much. If we can, it looks like we have another question. I was going to say we don't, but we do. Here's another question, and I think we have room for maybe a couple of more. Question: how do you recruit community advisors? And this is coming from the community you're trying to connect to. Is it mostly on the spot discussion? Do you look into their educational or work background? How do you do that? Dr. Ford?
So there's no blueprint. And I will say the communities have probably 6 different approaches to how they've built their CABs. And so some communities are, I would say, I'm going to use in this context more advanced in that because of the urgency of COVID and other health inequities, there were already different boards that they could pull from for this project. And so this folded in and complemented nicely existing citywide or countywide efforts. Others, it is about making sure that residents are heard. So many communities have community zones or districts that have community leaders or representatives. So starting there and doing recruitment. And, really it's about the needs of the community. So I'm going to shout out New York here in terms of a housing. They really are focused on housing. And so their advisory board maybe leaned more to expertise there. There are other communities that are looking more at, in terms of experts that may speak to more social injustices like, I don't want to name a few here, but I'm thinking of Albany. Their community was based on just needs they saw based on some of the data points in terms of the social health disparity, social inequities that they saw in the community. And so I would say it's case by case. And that's a question that we are happy to connect you with our community partners on in terms of best practices that they've used to identify best voices for their advisory board.
And also I would add, there are a number of different models for building out community advisory boards. For instance, there's a community-based participatory approach. There's also a community partnered participatory approach, and they sound similar, but they're actually just slightly different. But those models really walk one through step by step of how to do it. And it puts you in community with other, essentially a community of practice with other organizations around the country and actually around the world who are using those models. And so I think, for instance, APHA does have a CBP, or a community-based participatory research work group, as many of you may know, and they, caucus, and they actually, joining that caucus, learning from that caucus is a way to be in partnership with others and supported by what they're doing more broadly. Yeah, I'll stop there.
Thank you so much, Dr. Ford, Dr. Ponder. We have reached the end of our webinar today. I want to thank again all of the attendees for joining us for this very important conversation. We will be providing you the video of this webinar, which includes all of the slides. I know we've had several inquiries about that, so you will get that. We do have your unique emails, and we will make sure that we send that to you. And I just want to thank everybody on behalf of the team. Thank you. I appreciate being your moderator, and I'm going to turn the last word over to Dr. Ponder.
Thank you so much, Dr. Brooks, for facilitating today's conversation. Everyone, I want to thank you for joining today's conversation. Please follow along of our work at Project REFOCUS. We'll make sure that Ms. Frazier is in touch with you in terms of our summit and any reporting that come out of phase 2 in terms of our lessons learned. So we appreciate your time today. Thank you.
Thank you, everybody. If everyone on the attendee side could please sign off. We appreciate you.